Okay, let's turn it on, Matt.
You've been on. We're live to
Perfect.
128 so far.
Thank you very much. Sorry for that dead air. It's something we always try to avoid on the radio. Hey, good evening, everybody. Thank you for attending tonight's Zoom info session. For those of you that don't know me, I'm Bob Griffin. I'm the Dean of the College of Emergency Preparedness, Homeland Security, Cybersecurity. It's the last time I'm going to use that full title tonight. I'm just going to refer to it as CEHC if that would work for folks. I got a few introductory comments that I want to give you, and then we're going to bring up the panelists. I'm going to give an opportunity for our other faculty members who may be on to make a few comments, and then we're opening up for your questions. For your questions, you can use the Q&A feature, which is down about right here on your Zoom bar. So take a look at that. So it's an old Chinese proverb that says, or some I guess would say it's a curse, may you live in interesting times. And we are all living in really interesting times. Candidly, we're living in times that we're making up a lot of the rules as we go. And I think that's part of the challenge that we want to talk to you tonight. When I say we, we're talking the combined info session with CEHC and the School of Public Health. A couple of comments about pandemics before I turn the mic over. In my estimation, pandemic is the hardest and worst case scenario that emergency preparedness, Homeland Security, and public health professionals have to deal with. When I worked at the Department of Homeland Security, I struggled with the pandemic scenario planning because it runs contrary to all of the best practices that we try to teach in emergency management. So you think about a situation like a hurricane or an earthquake that have a huge regional impact, but can be addressed by linking local government with state and federal resources. And frankly, you can link through the mutual aid agreements through either the EMAC agreements or through Stafford. We are able to move resources and really focus the resources of this entire nation to deal with that problem. The pandemic, however, forces us to pretty much go alone. Since that hope of mutual aid and support from others is not coming because frankly they're all being impacted. The difference between a pandemic and other emergencies is being played out almost hourly. If you've watched the news, like I know many of you are doing, you're seeing at times confusing or contradictory information. You're seeing information changes as we get better intelligence. And you see the struggle that we as public health and emergency management professionals are going to struggle with, and that's how do you prioritize scarce resources to do the most good? And realize that for every respirator that we send to California, that may mean that somebody has to die in Michigan. And how do you balance both the regional needs but the common good? This is also why I think that federal leadership is so critically important in the situation. It doesn't do us any good to lock down New York if our neighbors are not locking down and basically their residents are continuing to spread the virus. It's also important to note that the federal government is the one that can propagate the rules and regulations that control the mean of productions, control the vast resources, including the resources in the Department of Defense, particularly with you start to think about the Army Corps of Engineers and you think about the medical capabilities there. The federal government also controls resources like the pharmaceutical stockpiles of medical equipment, the disaster medical assistant teams called DMATs, and sadly, what we also call DMORTs, the teams that deal with the disaster mortuary services. This pandemic raises just enormous questions about the state of our nation's federalism, the disparity between rich and poor, questions of individual liberties versus common good. And frankly, for all of you, I jokingly call CEHC as the college of full job security, but in reality, you will spend the rest of your careers thinking through and working through the dimensions of this crisis. So tonight you're going to hear from some just incredible experts in the field of pandemic planning and preparation. Our panelists will give you a broad overview of the situation from a macro, a micro, and really a sub-micro, even regional perspective. You'll hear a bit about technology and what technology role can play, and you're going to hear a lot about how we start to think about vulnerable populations, remembering what President Rodriguez is saying about making sure that we continue to have empathy and support. What I'm hoping to do is that you'll get a sense of what is happening behind the curtains in policy and governance and response. And in part, what I'm looking for in tonight's question and answer period is the ability for you to start to put together real practical questions based off the theories that you're learning in your classes. I want to set a couple of ground rules though before we go on. We are learning like you as we go. So if this isn't perfect, we will work to make it better. Second, please remember to hate the virus, but love the people. I despise the term Chinese virus because it promotes division, name calling, and group hate. Again, love the victims and their families and hate the virus. At a human level, please remember that all humanity is suffering, not just one group. More than ever, we got to come together as a nation, but also as humanity to pull ourselves out of what could be very dark times. With that said, there is plenty of hope and optimism that we will not only recover, but recover stronger. And I think you're going to hear some of that in some of the words of the panelists. It's my pleasure to introduce our first panelist, who's going to be Dr. David Holtgrave, who is the Dean of the School of Public Health. And for those of you who are not aware of the huge diamond that UAlbany has in the Dean of Public Health, Dr. Holtgrave comes from UAlbany after a long tenure at Johns Hopkins. He worked with the CDC. He has built just an incredible resume as a noted expert in the spread of disease and pandemics, particularly in the area like HIV spread. I can't tell you how beneficial it is to me and to CEHC to have a counterpart and peer like David Holtgrave. We're really lucky to have him because he's actually been drafted by the governor and is working closely with the Secretary of Public Health, advising both the Secretary of Public Health in the state and the governor. So it gives you a sense of the horsepower that Dr. Holtgrave brings to us. Also pleased to introduce Dr. Didi Bennett from CEHC. Many of you know her. For those that don't, she is a noted researcher in areas of emergency management, disaster communications, and vulnerable populations. Dr. Bennett has an incredibly impressive resume of research, but it's research that is leading to applied operations, that her work is actually changing how we operate in the field and really lives up to the motto of making a difference. Dr. Bennett will talk about her findings and how we can think about using technology to work not only with vulnerable populations, but to think overall in both public health and general emergency management. I've also asked Dr. Mary Gallant and Dr. Jennifer Goodall to jump in the program during the Q&A session, especially if you have questions, specific questions about issues pertaining to what's happening on the university. So with that said, I'd like to turn the Zoom over to Dr. Holtgrave to make a couple comments.
Great. Thank you very much, Dean Griffin. And first of all, thank you very much for that very kind introduction. I have to say it's just terrific to have the partnership with CEHC and the School of Public Health. I think we're, as two schools, are trying very hard to address some of the same challenges from very synergistic points of view. So it's a tremendous partnership, and it's great to get a chance to work with you, Dean Griffin. Your tremendous experience in government and academia is just incredible. So we learn something new from you all the time. So it's really a privilege and an honor to be able to get to collaborate with you. And thanks for making this a two-school town hall this evening. I think this is a good model for how we can work together on such dialogue. So thank you very, very much. And also very glad that Senior Associate Dean Mary Gallant is going to join for the Q&A session. So Mary, thank you very much for being on this evening. I'll just say a couple of words about where we are so far in the pandemic. And I think these are things that if you only turn on CNN, you see now they have the ticker going on the count of cases and deaths on the side. You can't miss this. But now we have about 372,000 cases globally, about 16,000 deaths in 168 countries. In the U.S., we're at about 42,000 cases and 520 deaths. And importantly, and close to home here in New York, we have just over now 20,800 cases. And if you take that 20,875 cases and divide it by the number of tests that have been done, which is a little over 78,000, that's about a 26% positivity rate, which is a very high positivity rate. And if you look at the number of new cases in the last 24 hours, it's 5,700 new cases in the last 24 hours in New York, and out of 16,700 new tests. And I'm, of course, rounding all these to the nearest 100 or so. That's a seropositivity rate of just over 34%, meaning that our testing efforts are increasing in New York, but at the same time, we're really still in a case-finding mode. We haven't moved far enough along that we're seeing the contours yet of this pandemic, which is really important to keep in mind. In New York, just over 3,600 people are hospitalized and 621 are in the ICU. So a substantial number of people are really receiving quite substantial care. And just now on the federal press conference, Dr. Debbie Birx was saying that in New York City, the attack rate of the virus is now about 1 in 1,000 people, which is a remarkable statistic to think that about 1 in 1,000 people in New York City are living with this novel coronavirus. But at the same time, as Dean Griffin said, I think there's important sources of hope out there for us. And those largely are to be found, I think, at the moment in South Korea and in China. And if we look at the curves from those two countries, and I'll just use South Korea as an example, the number of tests being done each day continues at a very high level, but the number of new cases each day is declining. And I think that's really important because what it says to us for South Korea is through a combination of testing, contact tracing, and some social distancing measures, they've really been able to find the contours of this epidemic and see it through a bit to the other side. There's still work to be done, but I think that's a source of hope for us, that it is possible in a few weeks' time to be able to get through this, but we have to make the short-term sacrifices with social distancing and testing and contact tracing and medical care to be able to get to that other side. Here in New York City and Albany, it's important to note, though, we have a shortage of tests right now. The resources are such that to be tested in Albany or in New York City, you have to have symptoms and you have to be hospitalized or about to be hospitalized in order to get a test, or you have to be a healthcare worker. And that's really important because what it really says is if you're symptomatic, even with moderate symptoms, but you're not yet ready to be hospitalized, you're not quite severe enough to be hospitalized, you're not going to get a test. And so what that also suggests is there's a pool of people who are ill, but not quite ill enough to be hospitalized yet, that are not being counted in these statistics that I'm talking about. And so I think that's something we're going to still find out more about. One of the things I'm really hopeful for, and I think New York State intends this to be the case, is that as resources are limited for the testing, we have to be able to push through those resource pinch points, as they're sometimes called, and get through the other side. So if we have a shortage of testing or personal protective equipment for persons who do the test, it's important to be able to get through that time period so we get through to the other side of this, so we can really get to much more widespread testing again, like we've seen in South Korea and China. And then just lastly to say something that Dean Griffin alluded to earlier, in SPH, there's been a number of faculty, Eli Rosenberg, Janine Jurkowski, Tomoka Udo, Elizabeth Rosenthal, and a number of students have been working with the health department over the last couple of weeks in a wide variety of tasks, and I've been kind of pressed into service in the last day or so as well too, which I'm very happy to do. And it ranges from trying to work with the state on kind of getting out quick scientific papers that need to be done to trying to figure out how to assist them with this drug study for chloroquine and hydroxychloroquine and azithromycin to judge whether it's both safe and effective in the context of COVID-19. And also, there's so many mathematical models that are being done out there right now. It's important to be able to help interpret what do all those models mean and what are the common lessons that they suggest, both for when this epidemic might peak, but also what will we have enough hospital beds and ICU beds and so on, and how many would one need to get through the peak. So those are a few things that we've been working a bit with DOH on. And as Dean Griffin alluded to earlier, I just wanted to say we're really proud of all the work that's been done across the faculty, students, and staff in the School of Public Health and in partnership with CEHC. Today, as we've all went to temporary remote learning experiences, we're all learning as we go along here, both how to deliver these courses as well as to participate in these courses. And same way to do research. Everybody is now trying to do their research program at a distance, and we're kind of learning as we go of how to do that. So I think we're really interested to have a Q&A session, but also to really just listen to and hear what these experiences have been like in getting ready to do that. So I think at that point I will stop, except to say I apologize the fact that I had a little IT problem with my camera that I'm trying to fix, and I'm realizing I'm not a very good IT department, but I'll try and rectify that in the days ahead here. So apologies, I'm just on the phone. But I think, Dean Griffin, I'll turn it back over to you if that's okay.
Thanks, David. Really appreciate that. And remember, if you have questions, you can start putting them into the Q&A section. The more you put in now, the easier it's going to be to answer them afterwards. Thank you for your comments, Dean Holtgrave. Dr. Bennett, are you ready to present?
Hi, yes, I wanted to share my screen, but it looks like I cannot. The host disabled.
Matt Tyler, is a way to share the screen? Wow, you have a very yellow screen, Dr. Bennett.
That's not my screen.
You should be able to share your screen now.
Okay, thank you. This looks a little bit different, so I'm not sure if you'll see it. Okay, is everyone able to see that?
Yep.
Okay, great. So like Dean Griffin mentioned, I was going to talk about technology and vulnerability during COVID-19. I'm not talking about ongoing research so much as I want to give you thoughts and concerns about what's happening so you can kind of see where my research actually converges. So since we are, dealing with everybody kind of rapidly and ubiquitously moving to online education and using the internet, there are some things that I thought we should probably start to think about. There are innovative technology solutions that are being deployed fairly quickly, especially in terms of communication. So we're doing this video conferencing all across the world. They're doing video conferencing. We're also moving to remote education and online education, and we're not the only ones. All across the nation, universities and colleges are actually moving towards remote learning, and I've already checked, and I can find at least 2-3 universities in every state and most territories that have already decided to move to remote education. And educational technology vendors are actually confronted with this sudden opportunity and also some risk that are happening there as well. And while we're moving for these things for both our learning as well as our work, we're also doing it for social integration, because while we're doing social distancing, we're starting to see people connect with not just their internet, but through social media and mobile devices. And though those technologies may or may not be new to you, the way in which they're being leveraged is slightly different. And so for those of you who may be feeling really social isolated, you should know that there have been some interesting things that have happened online. There's been some clubs and concerts created online to help with social distancing, and it even had some famous viewers. So you can see here, like Baltimore Symphony Orchestra and DJ D Nice have had some online concerts, and so that's something that's kind of unique and happening online as well. But beyond the communications point of it, there's also the delivery of certain services, which has led to us rethinking what we're going to do going forward, especially in terms of mitigation. And so they're starting to see that there is this hastening of adoption of autonomous vehicles and delivery robots. And I even saw some things around the use of drones, and if we're going long term, what that means. And so that's a nod to our drone facility that we have at the CEHC as well, but that we're going to be looking at some of these things and how it's being leveraged in this type of crisis. And beyond that, we're looking at artificial intelligence as well. And so managing the coronavirus and trying to fight this pandemic, we're seeing artificial intelligence being used with data science and different types of technology to actually track what's happening. And while some of this is being leveraged a lot heavily overseas, we're starting to see some of this happening in the US as well. And that also brings us to the idea of our healthcare services. And I started noticing that we're moving to things like telehealth. And so telehealth and e-health or telemedicine, we are moving towards those specifically for this as a care option during this outbreak. But I even know specifically that some physicians and even psychiatrists and therapists and things like that are moving towards it more permanently for different solutions. And so we should be thinking not just about what's happening right now, but how this may also impact things going forward. And while it may be an option for us now, it's not always an option for everyone. And so we're in this very precarious situation where we're just moving very quickly, and there are some people that are being left behind. So what we know through disaster research, two points that I think most of my disaster researchers on here will agree with me, is that disasters often exacerbate inequities that were already present prior to whatever the event is. And we've seen this through natural hazards. We've also seen this through technological and human-induced hazards as well. And we're seeing it happen here during this pandemic as well. The second thing is that there are populations at risk who are more prone to be socially vulnerable during disaster. And again, this is throughout any type of disaster, kind of all hazard situations. And so when thinking about that, I wanted to pose to you two things: that there are different populations at risk during COVID-19. And so while we're thinking about it, I think most people talk about the physical vulnerability of certain populations. And that tends to be older adults, and we hear about people with pre-existing health conditions, but those aren't the only people being impacted right now. Other individuals who I would also consider being physically vulnerable are the first responders, and those don't look like exactly the first responders that we thought about before, but it includes our cashiers, our medical staffing, cleaning staff, which I don't hear enough about, the cleaning staff that's actually cleaning up after everyone, and the pharmacist and your utility workers and things like that. And we were even talking just earlier about the fact that it's snowing outside right now, and I haven't seen a cleaning crew out there because I don't think they're considered essential. But depending on what's happening, you'll have different people out and about. But beyond that, there are some individuals and groups of individuals who are considered socially vulnerable, and they're socially vulnerable throughout any disasters. And so sometimes we see this overlap. Here, we'll see it overlap with some of these physical vulnerabilities, but I don't want these other vulnerable populations to get lost. And so that includes, again, older adults, but it also includes children, people with disabilities, could include pregnant women, certain racial ethnic minorities, low-income populations, individuals without access to transportation, which is probably really key right now, and certain gender minorities, including LGBTQ communities. And so what does that look like going forward when we think about some of the policies that we've put in place, we think about some of the technology that we're moving towards. There are individuals who, because of our social isolation and social distancing rather, that are going to be impacted because of not being able to continue their jobs and things like that. So a few potential impacts that I wanted us to sort of think about. I would be remiss if I didn't talk about a little bit about the mixed messaging and disaster communications kind of 101. And though that's not about the technology itself, but it's about the messages that are being sent on the technology. One is that we definitely need to make sure that we have clear, concise, accurate, and honest communications to individuals and limit the use of jargon. And jargon doesn't necessarily look like the alphabet soup that we usually get. Actually, this social distancing actually tends to be a jargon. I can hear people describing it online, and I see that it's a lot different the way some people say I can go outside, but I can stay 6 feet away from someone, versus if you were thinking about it long term, like, okay, well, if I just stay inside the house and not see anybody else and not try to interact with anybody else and maybe get my groceries once a week, that's a little bit different, a little bit more clear and specific. If someone thinks I'm supposed to stay inside my house and it's indefinite, which is kind of what we know, then maybe you see people trying to hoard or trying to keep more groceries and things like that inside their house because they don't know when they're supposed to leave. So that can also impact, and we've already seen it impact what's happening now. Beyond that, though, our rapid and ubiquitous use of technology is very interesting to me because there are several of us that are not technically savvy. So as we move to these new technologies, and that includes our students, as well as our faculty, as well as anybody who's actually staying at home to work, that are not as familiar with different types of platforms, different types of programs and applications that we're quickly moving to. There's also this thing about people not being without internet. According to Pew Research Center, their last look at how many people had home broadband use, there was nearly 25% or up to 25% without internet in the home, which means that they're forced to use just their cell phones to get information through. And so that means that if you're asking people to do their bills online, you're asking them to get all of their information online, do their homework online, as well as, you know, maybe work online, you're asking a lot from a little mobile device that may or may not be able to do it. There's also inherent biased policies, procedures, and practices that some were putting in place. When you think about our low-income communities, our low-income households, and low socioeconomic communities, you'll realize that some of them are way more at risk for losing their livelihoods, not just their life, but the fact that if they're unable to pay their rent, if they're unable to purchase the foods and supplies that they need to stay at home, that is going to cause some consideration. What if they can't afford to get whatever internet or technology or computer that they need to maintain their jobs? That could be a problem as well. And finally, a nod to our cybersecurity folks here in the college, but there are some privacy concerns with us moving as quickly as we are. And that's not just in the home, but the way in which we're using different surveillance for coronavirus. And I've heard some things about tracking of phones and things like that. And while I know that's happening a lot more overseas, but it's still something to consider now. There's also security concerns as we're moving to some of these technologies. Are we actually thinking about the privacy and security of the people that are using it and the providers that are using it as well? And that's especially true for things like telehealth and telemedicine. And as we're moving as quickly as we are, everybody doesn't know or understand what's happening behind the scenes. And finally here, I just put a nod to spam alerts and things that are happening around targeting individuals because we're moving so closely and because a lot of people don't have the information that they need. I've started to see in the news that there's this uptick in people being targeted and for spam and for, spoofing and things like that. So my research is really this connection between the two, what's happening in terms of technology and how can we leverage that, and also where the gaps are, where we aren't seeing things in place. And some of it is very high level technical, but some of it can just be social impacts. One thing that has come up, especially in my research and with people that my colleagues across the nation are talking about, is the fact that every single press conference that we have, every single time we're talking about in the news, it's not actually being led all the time with someone who is an ASL interpreter. And so there are a lot of deaf individuals who are now saying, I don't know everything I need to know about how to keep myself safe. And so that's also a gap. And that's something that's very small that we can think about doing. So I did, because we were talking about students, and I know there's tons of students online, I saw this at the University of Maine. They had this little clue tip sheet on becoming a remote learner, and I thought that would help reduce some of the anxiety for the students that are moving online. And this is something that most of the things here I talk to my students about before getting them online. And I thought that would be kind of useful here. And the one thing is to make sure you're creating a weekly schedule so that you know what you're doing in all your classes, and acknowledging the learning curve. And that learning curve is not just because of, learning all this stuff from your professor, but it's also about the learning curve of how to use this new technology that you're being required to use, that for most of you weren't using 2 weeks ago. So that includes this Zoom that you probably will be using in your classes, the video feeds that if your professors are using, and the Blackboard if you haven't been using it in your class. You're gonna have to get to know a lot of the different features there. And just like when you're in class, making sure that you're checking your communications often, you're collaborating with your classmates, and you're still respecting the honor and honoring academic integrity, because that doesn't actually go away. We're all here to help you and to ask, so you can ask questions pretty freely, and make sure you check in with your advisors. I know we have a couple advisors on here today so that you can also think about it. And then for your own mental sanity, since we are at home and staying at home, and hopefully you guys are too, make sure you take short breaks and build those into your schedule so you don't actually lose your mind or lose your place. And I thought that was a really, really cool thing that they had, so I wanted to share it with you guys. So thank you so much. And if you have any specific questions for me, here's my email. Thank you so much.
Okay. Dr. Bennett, thank you so much for that. And I know we had a lot of questions coming in. So why don't we start to go to the questions? But before we do, I'd be remiss if I didn't thank the Dropkick Murphys for the live St. Patrick's Day show on last week. So Dropkick Murphys, thumbs up. Thank you for what you did. Okay, we're going to start to take some questions.
So I've got a couple of questions here. There are a few students who are asking about the peak, when the peak is expected to hit the US, when it's expected to hit New York, and in New York specifically, what's the estimate on how many people will contract COVID-19?
Yeah, I'm David. I'm happy to start, and others may want to comment on this. I think the governor in his press conferences has been talking for about a week or so now about an estimate that the peak might happen in about 45 days or so. So we're probably 5 to 7 days into that. And also he's had a slide that he's used on a couple of occasions putting the estimate that it's possible if we don't do anything that we could see 40 to 60% or even more of the population come to be living with coronavirus. And I want to say two things though about that. I think what we've seen, so this 45 days kind of comes from mathematical models that have been done. But if we look at what we've seen in China and South Korea, it also kind of fits. If you do the right testing and contact tracing and social distancing, they saw their peaks happen a few weeks in. Sometimes it's more like a couple months, but several weeks in. So sort of, I think, on that order of magnitude. The other thing I would say is when we see in the media estimates like 30 to 60 or 40 to 80% of people becoming infected, most of that, I would say, is based on an assumption that we don't do anything as a society. We just kind of let things wash over us in the epidemic, and that we're not doing the kind of social distancing and so on that's necessary. So I think ultimately that percentage is likely to be substantially lower than that. I don't think we know exactly what that will be. But it feels to me like those kinds of dire predictions are what if we froze as humanity and didn't do anything in response. So I think it's going to probably be substantially less than that. Certainly hope that's the case, but others may want to add to that or comment on that.
Yeah, one of the concerns that I have about the spread is something that I'm watching out of Hong Kong, where I think that they took some really good measures initially to deal with the virus outbreak, but they let up too early, and now they're starting to see a second wave. And I think part of the learning that we have to do from Hong Kong and Korea and Italy and Spain is make sure that we are cautious enough and have processes in place long enough to be effective, because you can have multiple waves.
I have two follow-up questions. One, is there any evidence pointing toward the effect of seasonal warmth on the survival and transmission of COVID-19?
I'm happy to start on that as well too. So far we don't see that. I think that's a big question that people are looking for evidence about. So far we haven't seen, given that now the virus seems to be present in about 168 countries, some of which have much warmer climates at the moment, some which lesser. We don't seem to see it be driven so much by temperature at the moment. So, and the other thing is that the doubling rate of the virus at this point, we have so much inertia for it going forward that you would expect to see some of this, even if there is some sensitivity to temperature in the summer months, you'd expect to see it kind of barrel into the summer, if you will, and that we wouldn't see quite the slowdown we might have seen otherwise. So, I think one can be hopeful that that might be the case, but so far we're not seeing seasonality effects or temperature sensitivity, but people are looking for that all around the globe.
This was not the second follow-up question, but there are a bunch of questions about this, asking specifically how the virus may affect next school year.
I'll start, David, and you can jump in, and then Mary and Jen, when we say something incorrect, you can correct us. I think there is a potential that this could go into the fall, but we really don't know at this point in time. If our procedures and everything that we're trying work out well, hopefully we can get through this at a relatively quick pace. I don't think it's going to be a matter of a couple weeks. And I do think it's going to last into the summer. So the virus itself certainly could have impact in the fall. Honestly, I don't think anyone who is in academia or coming back to the university is going to be untouched by this. I think this virus is also going to dramatically reshape how we provide services and how we think about what we do and the type of classes we offer and the type of training that we give to you all to make you better prepared to go out into the workforce to deal with these problems. And again, the skill sets that all of you are getting in both public health and in EHC are going to be in huge demand. And I'd be remiss if I didn't comment a little bit about the informatics program and the issue of data sciences and and how we start to really integrate and more comprehensively issues like AI and machine learning to start to help us better model and address some of these pandemics. It's been a long time since we had one of these, but it won't be the last.
Sorry. So another sort of group of questions that we have are people concerned about doing online or virtual classes, and just sort of the general discomfort with that. Are we going to be moving, is the world moving to online classes? Thank you, Dr. Bennett, for the tips. Does anyone else have tips on how to handle this transition?
Go ahead, Bob.
I was going to say, Dr. Bennett, do you want to start?
Yeah, I was going to add that we do have a website, just in case you guys were not aware, on the Albany website. I'll put it in the chat here. But it basically has all this really cool information on how to use Blackboard and how to use Zoom as a student. And I think one thing is, if you're very nervous about getting online, is to try to familiarize yourself with the programs and the applications. And then the rest is getting yourself on a schedule. And I think that's the main two things.
David, do you want to jump in?
Well, I'll just make a comment, and Mary, you may want to add to this as well, too. I kind of make a distinction between what I'd call online classes, which to me mean sort of permanently shifting to an online format, and what I would call temporary remote learning experiences. And I think at this point, a lot of what we're talking about are sort of temporary remote learning experiences. Much of the learning in SPH and in CEHC, if I can dare speak for CEHC as well, is very experiential, very learning on the front lines, and that there's no substitute for that. But at the moment, to sort of get through the current crisis, developing temporary remote experiences that can get through the key objectives of a number of courses. And it won't be entirely perfect, but at the same time is a way to move forward. I don't know, Mary, anything you wanted to add?
I'll just add a couple things. I want to reiterate a couple things Dee Dee said, in that I really encourage students to utilize the resources that are provided on the Keep Learning website at UAlbany to, take advantage of the information that's there to learn how to use these remote technologies, but also to stay connected with your peers, with your instructors. One of the things I really want to emphasize is, your instructors want you to be successful. And so I would really encourage students to reach out, don't hesitate to reach out to instructors with concerns if you're facing challenges, and to make an effort to stay connected even though we're not physically connected.
Yeah, and if I could just add a couple of thoughts, and it's along the themes that I think Dr. Barrett and Dr. Gallant have added. Stay involved, and that means both socially and academically. We're going to try to do some things in the next couple weeks, including see if we can't do a virtual game night. We're talking to our faculty about doing some TED style talks to keep your academic juices flowing, and read your emails. I know it sounds really funny, but we're pushing a lot of information, and it doesn't do us any good if you're not reading and frankly responding to those emails too. So that if something doesn't make sense, don't hesitate to contact us. I know I can speak for all of the faculty across this university. We're in this with you. So when you are feeling stressed, when you're feeling angst, when you're kind of pulling your hair out, reach out to us. You probably find that we may be feeling the same way, but sometimes just the idea that we're sort of working through this together will help you. A couple comments about online versus remote. We're social animals, and I still think some of the best way to educate is through hands-on experiential learning, and that means making sure that we have platforms that are safe for everybody to attend, but equally important, allow us to continue to share the goodness. One of the things you'll sort of realize as you get a little bit older, like me, how much I learned from other people, and how much I learned from my peers, and you don't even realize how much goodness you absorb just by sitting with your friends and peers in the campus center or in your dorms, and I think that's critically important. And for those of you that are already scratching your head saying, "Oh my God, this is only day one," my parents are driving me crazy, like my sons are probably saying. This is why living in your parents' basement isn't a life plan too. So stick with your education and get a job, and you can get your own place.
We have another series of questions asking when things will go back to normal.
You know, I don't know what I'm gonna go out and become very philosophical for a second. I think that the pandemic will permanently alter some societal structures. So I think what is, quote, normal is going to absolutely change. Certainly, I think the prioritization that we have done as a government needs to be looked at and frankly substantively overhauled. So I think that there are. I do think we're going to get back to the days of being able to go to the coffee shop or the bar or the movie theater, the mall, going to concerts. That will come back. But there are whole elements of society that I think we're going to have to work. And frankly, for the students, that you're going to spend a good portion of the rest of your careers working through issues like making sure that our hospital systems and medical systems are more robust, that we have safety measures put in place so that nobody should ever fear for the lack of medical help. I think that the issue of how organizations, both private sector and public sector, handle emergency planning and preparedness, particularly in light of a pandemic, shows enormous weaknesses in the system. Again, the good news, and I hate to sound like I'm trying to polish a grim message, but this is why you're UAlbany. This is why you're in public health, or why you're in emergency preparedness, why you're in informatics. This is what we're training you for. And you, more than anybody, are going to help redefine what normal is and help us put our communities back together again. It's not going to happen overnight, though. Any other comments, David, Dee Dee, Mary, Jen, anything?
I was going to mention that if this follows anything like the other disasters that we look at, and if we're good at mitigation, we should anticipate some elements of a new normal, but not, it's not going to be as drastic as maybe everybody thinks. But I mean, there are going to be some things that I already see it, even with the telehealth thing. So for example, some people are using it and realizing, wow, this might actually be a good option. And so maybe that becomes more prevalent of an option for people. And I know that there are some populations that have wanted it for a long time, and this has just kind of pushed it forward. So you may see some elements of us trying to mitigate something like this in the future, but also trying to be on the front of what works and what does work during this time.
David, Jen, or Mary, you want to add? Sorry, David, go ahead.
No, I just wanted to say I agree with everything about that Dr. Bennett said, and I think it does give us a chance to selectively kind of reboot things and discard other things. And some of the things like just how we do science, no one would have ever thought that the conference on retrovirus and opportunistic infection could be done online, but people seem to have quite a good experience with it. And I think in the future we may see more of those things happen. And I think the other thing this has really taught us is, as Dr. Bennett was saying earlier, like musicians and others coming forward. A friend of mine's a musician and had a online concert for about, I don't know, 300 people or so. And it was a way to reconnect with people all around the country and for a couple hours just feel a little bit more in contact with our friends again. And I think it sort of helps us value and recommit to some of those social connections. So I agree with all that's been said.
David, what was that conference again?
The CRY for short, Conference on Retroviruses and Opportunistic Infections.
Just remember, nobody parties quite like public health people do. Just want you to know that.
So another question we have is, do data provide any findings relative to test results based on socioeconomic factors like gender, race, ethnicity, and income?
So people are starting to trying to look at that. I think one of the things we found so far, but this is largely based on the data from China, is there does seem to be a gender differential. The fatality rate seems to be higher in men than women so far. I think here in the U.S., there's a lot of interest and concern to be able to look at social determinants of health, because clearly if we tell people to please shelter in your home, it presumes you have a home. If we ask people to bring in a certain number of food supplies, it presumes you have a certain amount of food stability. And I think those kinds of social factors are really key, but we're only beginning to get a chance to look at those right now. So more data to come, but gender was the first thing that we got information on. It does seem like there is a gender differential on fatality rate so far.
I would add here that if it follows the other public health data on I guess, health disparities, especially in the U.S., then you will start to see some things that kind of follow socioeconomic status and race in the U.S. So I think it's a difficult question to ask on the surface, because it just seems like you may be attributing the virus itself to attacking certain individuals. But I think it's more along the lines of what I was saying that we learned from disaster research, is that disasters tend to exacerbate whatever any inequities were already there. So if you live in a location where we have food deserts and you are low income, then you're less likely to get the supplies that you need. So it kind of compounds the issue.
And just to continue to add to that, I totally agree. And I think that we know that persons who are older have more severe disease, but also underlying health conditions. And to Dr. Bennett's point, I think a lot of those underlying health conditions like cardiovascular disease, compromised immune systems, diabetes, and other factors, there's tremendous racial and ethnic health disparities and gender health disparities and income inequality disparities in some of those underlying conditions. So I think there's a pathway there as well. I agree.
When do we expect a vaccine?
So I think we're hopeful, but Dr. Fauci from NIH, who I think is a really incredibly important source in all of this, will say that for a vaccine, we're probably looking at a year to 18 months. There's already some trials underway, some candidates that are being looked at. But since you're going to use a vaccine for persons who are negative to try and help keep them negative, you've got to make sure that you've got a really good safety profile before you start rolling it out to large populations of persons who are negative. So that will probably be longer. Treatment effects, hopefully shorter than that. There's certainly some candidates to be looked at now, including things like chloroquine and hydroxychloroquine and so on, and that there'll be trials of some of those existing drugs quickly, but it'll probably take a few months to get all the data in. At best, one could hope for a matter of weeks, but I think it's more like months. And then there's interesting treatment candidates that Regeneron here in the capital area is looking at, where there's kind of a theory that if you can use antibodies that persons who are living with this novel coronavirus have built up, that if they resolve the virus and you can still get the antibodies, you can use those antibodies to form the basis of treatment for persons who were becoming ill and earlier in the course of disease. And that's something that they're looking at very aggressively right now as another kind of candidate. So I think we're probably in the months for vaccine, probably a year and a half away.
And for everybody's, we're hitting our almost our 8 o'clock time. I know Dr. Holtgrave has calls with the state leadership in about 5 minutes. We'll take a couple more. Let's take a couple more questions, and then I really like everybody's feedback on whether this is valuable, and if it is valuable, we're happy to schedule some follow-up sessions. I think the more information that we can help push or to you and that you receive, the better everyone is going to be. So why don't we take a few more? If we have some health-related questions that we can throw some hard balls at David and some softballs at me, that would be great.
So what is the latest thinking regarding immunity, herd immunity? Can one get it more than once?
So another question, well, when I used to work at CDC, we used to say, what do we think and what do we know? And so at this point, we've got more of the what do we think than this and what do we know. It's another question that people are looking at. It seems like if you have developed it once and have resolved it, that there may be some immunity that you carry with you after that. But I think it's far too early to say that definitively. And similarly about herd immunity, I think those are areas we're still learning about. These are great questions, by the way. I don't mean to not answer them, but I'm just trying to be honest about what do we know and what do we not know yet.
So Dean Holtgrave, last question for you because you need to jump off. Will we ever be able to take a home COVID-19 test, one where we could remain isolated until we know we're not contagious?
Yeah, no, it's another great question. So I hope that that's on the horizon. I think what we'll see is the next generation is, of course, now the testing involves a nasal swab and a swab in your throat, and then it takes under the best of circumstances, quite a few hours, more likely a day or two, and if things are slow in shipping and that, it might take several days to get those results back. The thing that's just been approved by the FDA in the last few days is a rapid test that will get the results more quickly, and you can also administer it yourself. So it's a nasal swab, but not nearly so invasive, and you could do the swabbing yourself, put it in a container, give it to the healthcare provider, and that's incredibly important because now one of the issues with testing is that if somebody's doing that very invasive nasal swab, they have to put personalized protective equipment on, and that's taking personalized protective equipment away from people maybe in the ICU who need it to care for patients. So if we can get at least to this phase of that you can do the self-swab, that saves PPE. That means you probably get the result much faster as well. So that's the next step, and it seems like they're ready to do production of that within about a week. I think then the next generation is going to be home test, and I don't think there's been any estimates yet of exactly when a home test might become available to us. And I will apologize just while I have the floor. Dean Griffin's right. I apologize. I have literally 3 more conference calls with the state tonight yet, so I apologize that I'll jump off. But it's in very good hands here with Dean Golan and Dr. Bennett and Dean Griffin. So I'll say thank you. And again, the School of Public Health is very committed. If there's a need for another session or do one of these a week, we're very committed to doing that. We love doing things in partnership with CEHC, or if there's questions we can answer by email or something later, we're very happy to do that and commit to doing that.
Yeah, David, thank you for everything that you're doing for us. You know, you're working 20+ hour days, and it is deeply appreciated.
Right. Thank you very much. Take care.
Should we do a few more questions?
Why don't we do a couple more questions, and then being respectful of everybody's time, we'll sign off, and then I'm seeing some positive responses in chat, and we'll see about scheduling another one for next week.
So another question is, how will this pandemic, how is it going to further evolve CEHC to understand how to be prepared for future emergencies at the college or other group gathering areas?
You know, I think we're going to have to go back and take a really hard look at the the maximum of maximums that FEMA used to use as part of their planning. I think overall at both the national and state levels that we have not pushed the envelope hard enough in our training and our preparation and certainly our mitigation. So I do see a rework of not only the emergency plans in training, but certainly how we start to think about response and stockpiles. So I do see this as changing the curricula over time. What we're also doing is, we're starting to introduce degrees, particularly at the master's level, with concentration with our partners. So many of you may know that we are in partnership with the School of Public Health, developing a joint master's degree in emergency management and public health, and I do see sort of programs like that sort of cross over multiple interdisciplinary lines in order to provide education that is not just thorough, but it's also tailored in the sense of a curricula that will allow you to really show to prospective employers what your capacities and abilities are. I will remain, and I do remain completely committed to experiential learning, to the power of internship, to anything that we can do to allow you to get your hands dirty and learn in the field. I think it's critically important for both areas of public health and EHC in order that you do that.
And folks are wondering how students and faculty can help.
So that's a really excellent question, and I'd like all of the panelists to jump in on this. I'll start. One of the best things that you can do is that you can be educated. I made the comment about making sure that you're reading your emails, but take some time out of your day and read multiple different news sources. You don't need to read 1,000, but read at least 6 or 7, and look for different news sources that encompass both international perspectives and the full political spectrum of news. That allows you to start to make a decision on sort of what do you believe and what you believe your values are. Also watch for different opportunities. So, from EHC's side of the house, when Mike Baumgardner or Andy Connors or Andy Crease or any of these folks are sending you emails with opportunity, jump on it. Right now, we have the Volunteer Operational Support Team that's working with the Directorate of Homeland Security and Emergency Services here in the state. I know that the public health students are working really closely with the Department of Health for the state, and I do see more opportunities coming. And frankly, we're going to be requesting help because the burnout factor for folks that are working 20-hour days like Dean Holtgrave are is pretty significant, and we will really start to see crashing in the trained personnel and emergency operations centers that we may be able to bring students in to help with that situation. So be knowledgeable, be ready for the call, and be as educated as you possibly can. Mary, Dee Dee, Jen, any thoughts on that?
So I guess there's 3 things I'm going to channel inner emergency management. And I would say, because we're changing so rapidly, is try to make a plan for yourself. So that's whether you're a student or whether you're faculty, try to make a plan to keep yourself sane. And then second is reminder that you have to be flexible. So be prepared for that plan to not necessarily go the way it needs to go, but be flexible in the fact that, build in spaces for the opportunity that maybe you're not able to do this or that. And also be patient, as everything is so fluid and changing hourly almost. It's going to really be difficult to be able to even answer the questions that you guys have here today with any certainty, because everything is changing and we're learning as we go, and that's happening clearly nationwide and globally. So at just the university level, when you're trying to figure out how you can do to help whatever's happening here, even in research or helping what's happening in New York, you're going to have to be patient with understanding where people are, what they know, and when they need you. So those were the three things: make a plan, be flexible, and be patient.
And on the, if I could just jump in for a minute, say something specific on the public health side in terms of volunteer opportunities. So Professor Janine Jakowski is taking the lead on sort of fielding requests. She's only gotten a couple so far from some sort of county health departments looking for help, but she's currently sort of coordinating that, and there may be a call, once that's organized a little bit better, there may be a call going out to students, or there might be a link on our website. So just pay attention to emails or announcements you get, the newsletters you get, and any volunteer opportunities that are available will be publicized there.
Yeah, there's great opportunity here as well. So we're sort of running out of time, but here's my commitment to you. We will schedule more of these. Actually, I'd like to get on at least a weekly schedule. We can take some of the questions that we haven't answered and start the next session for questions specifically about university policy. Then we can help shape the frequently asked questions list that the university is putting out. So watch both on our college's websites, but also also UAlbany site, because I think that is we're putting some really good information there. And then what I would propose is that we sort of start in a similar way, but with other faces. I think this is a great opportunity to bring some of the other amazing faculty who are on right now. I see the names of Dr. Stern and Dr. Turetsky and others, Dr. Penta, Dr. Greer. Sorry, my Boston accent comes out every once in a while. And we've got great faculty from the School of Public Health. So I'd like to start to bring different faces and names to this. But the commitment to you is that if you give us an hour, we'll give you lots of information. So why don't I wrap up with this? I made the comment about may you live in challenging times, but frankly that's what we at CEHC and the School of Public Health are built for. We go into these fields because we care about our communities, we care about people's safety and well-being. We want to make the world a better place, and we're in a position, and frankly you're in a position to actually make that happen. So while the news may be grim, also look at this as an enormous opportunity to really shine in an area that you care about. I know the commitment that I've made to you from our faculty in both schools, and frankly the entire university, stands. If you need anything from us, don't hesitate to reach out. If you're lonely, don't hesitate to reach out. Don't forget that continuing the community that you have developed, not just with the family at home, but the family here at Albany, is critically important, in that we all stand together, and together we will get through this. With that said, I would be remiss if I didn't thank Dr. Gallant and Dr. Goodall and Dr. Bennett and Dean Holtgrave, and certainly Matt Tyler, who certainly has been my crutch because I've been somewhat incompetent with some of the Zoom elements, and he's been terrific. And thank you for giving us your time. Be safe and have a great evening.